Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 30th, 2025. This video is on a paper published in the New England Journal of Medicine today, online, titled Beta Blockers After Myocardial Infarction in Patients Without Heart Failure. It was also discussed in the European Society of Cardiology meeting this weekend in Madrid. Beta blockers have long been used post-MI, but modern reperfusion and secondary prevention strategies have changed baseline risk. Their benefit in patients without heart failure and with preserved left ventricular ejection fraction equal to about 40% is uncertain. The BETAMI DANBLOCK investigators randomized trial was an open-label, blinded endpoint trial across 44 centers in Denmark and Norway. The study cohort comprised of 5,074 patients with a left ventricular ejection fraction equal to or greater than 40%. Median age 63 years, 21% were women, and 94.5% underwent revascularization. Follow-up was a median of 3.5 years, interquartile range 2.2 to 4.6. The primary endpoint, it was a composite of all-cause mortality, myocardial infarction, unplanned revascularization, ischemic stroke, heart failure, or malignant ventricular arrhythmias. What did they find? The primary outcome was 14.2% in the beta blocker group versus 16.3% in the no beta blocker group. Hazard ratio 0.85, p-value 0.03. Myocardial infarction recurrence was 5% in the beta blocker group and 6.7% in the no beta blocker group. Hazard ratio 0.73. No difference in all-cause death, 4.2% versus 4.4%. No difference in ischemic stroke, 1.6% versus 1.3%. No differences in heart failure, 1.5 versus 1.9%. And no difference in malignant arrhythmias, 0.5 versus 0.6%. Limitations: open label design, moderate beta blocker doses, low event rate, crossover about 11%, primarily metoprolol was used. Key takeaway: in post-MI patients without heart failure and with preserved or mildly reduced left ventricular ejection fraction, beta blocker therapy modestly reduces risk of recurrent MI and adverse cardiovascular events. Clinical pearls from this study: timeliness matters. Beta blocker therapy was initiated within 14 days of post-MI, showing benefit even in the modern reperfusion era. Recurrent MI reduced. The main driver of benefit was a reduction in non-STEMIs. In those with ejection fraction greater than 40%, even mildly reduced LVEF 40 to 49 may gain benefit from beta blockers. Choice of drug: over 94% of the patients received long-acting metoprolol, typically 50 milligrams a day. Contemporary therapy context: almost all patients received statins, dual antiplatelet therapy, and revascularization, indicating benefit on top of standard care. This is in a nutshell regarding this paper. Key eponyms: Göteborg trial 1983 led by Lars Hammarson, a landmark trial demonstrating early mortality benefit of metoprolol post-MI. ISIS-1 trial 1986 led by Rory Collins, showing atenolol benefit over 16,000 patients. Merit heart failure trial 1999 showed mortality reduction with metoprolol in chronic heart failure. In this study, in the BETAMI, lead author was Dr. John Monk-Hojen, and in the DANBLOCK co-chair was Dr. Anna Mette Christensen from Denmark. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.